So, okay. I thought that was the case from the beginning. All right, let's get to the next one. So this is numbers moving across time. This is cleaning up the axis part a little more to see what's happening. On the left side, you have basically the same data in a different form, which is suicide rates. Dark is bad. Light is either no data or low. And on the right side, with all the pink, pink and green type of colors, again, dark is a high on both sides of the spectrum. So green is good, and the reddish, pinkish colors are bad. So on the right side is the number of psychiatrists per 100,000, right? So kind of the correlate. This is the problem. Well, let's look at who can evaluate people. And the reason there are these two colors is basically they pick the mean for the country, and then they look at who's lower than the mean and who's higher. The East and the West coasts are higher. So that's why you have, New York up on the right side and then California on the left being green. And New York State, in fact, as a whole is a darker shade of green. And then you go the other way. And then what you see is a bit of an overlap here in this western part of the US, where not only do you have a higher rate of suicides, you actually have also less coverage in terms of people whom you would need to evaluate and treat folks who are suffering from these symptoms. So access is a problem. So among the people that we're talking about here, what's the distribution, right? Because another slice that you want to understand is who will you be serving? If you're going to create these apps, these technology-based tools, are you talking to a teenager? Are you talking to an older person? What man, woman, etc.? And current demographics. I am told that on Facebook you're dealing with something like 45 to 54 age females, right? On a majority. I don't know if it's true, but that's what I've heard anecdotally in terms of data. Well, so there's a nice little peak here on the left side, which has to do with the rates among women. So maybe that's an effective way to reach them if that's a useful route. On the right side is where you see the dark blue, and it's pretty obvious. On average, for every age slice, men have a higher rate of suicide per 100,000. Starts off pretty early and doesn't go away. The other thing that's not in here, which may be another target, excuse me, for technology as well, is the number of attempts. So this is talking about completion, right? Because something went wrong and it ended up with the person taking his or her life. But the attempts are different in the sense that on the female side, you tend to have more attempts per suicide, and then on the male side, you have fewer attempts per suicide. So if that were your point of intervention, then the graph would look different, and how you'd have to approach that would be different. So we've talked a lot about this data and slicing it a bit to sort of see who and where and what the subsets are that you'd want to target. Let's talk about depression, because again, people use it like a common word, but definitely in mental health, in treatment, it is not used in the sense of the common word. So this is from NIMH. It's one of the most common mental disorders. That's one of the reasons I'm talking about it here. And in the data you just saw, what this talks about is the definition that was used. And let me take a moment here to kind of discuss what that means. So there's this thing called the DSM-5, Diagnostic and Statistical Manual of Mental Disorders. So in a way, that's kind of the guidebook, or literally a manual that psychiatry uses as a discipline to sort of say, which category do you belong to? Do you belong to this clinical category of depression, or do you not? And say, you were diagnosed and now things are getting better. So then you ask that question again and you say, okay, are you still in that category, or are you better? And so basically, it's a categorical approach, one. And then two, that's kind of the ground truth, let's say, if you're going to talk about somebody either having a certain disorder or not. So that's the DSM, and you'll hear people refer to the DSM. That's what they mean. DSM-5 is just the most recent version. So that format, the DSM, was used to actually come up with the diagnostic labels that were applied in the graphs we just saw. So what are those labels? And it's pretty similar to what it turns out to be in clinical practice, this definition that they used. So a period of 2 weeks is what you're measuring. And in those 2 weeks, you have someone who has lost, importantly, interest in day-to-day activities in life, which they did have prior to those 2 weeks. And in addition to that, it's things maybe you, excuse me, relate to a lot more in terms of what you think about when you think about depression. So one is low mood, right, depressed mood. And then there's a series of other symptoms that come along for the ride statistically. And one of those is a problem with sleep. It can be either too much or too little. Another one is appetite. You're either eating too much or not enough. Energy is pretty consistently low energy. Concentration is consistently impaired concentration. So, a very common thing, somebody might take more time to do exactly the same thing they did before, and maybe even do it not as well. Self-worth is this idea of feeling guilty about things, having a low concept of themselves, which can really impair them, because if they have to go do something and they don't feel like the self-worth is good, then they don't want to even try the things that probably are really good for them, like, for instance, seeking treatment. Oh, it's not worth for me to go get treatment. Okay, so that's a problem, because you can give all these resources. Well, how do you get them from A to B? And then there's other things like excessive guilt about things. So for instance, something happens to someone related to them and it's very real for this person. They actually think that, oh, this is my fault, even though in any rational way, it's absolutely not. In practice, in clinical practice, this is one way this assessment differs. In clinical practice, you have a lot of subcategories. So one of those subcategories could be if there's a substance use problem. So what does that mean? Illegal drugs, right? Somebody's using alcohol or some other illegal drug. Some of those drugs can have an impact on you where your mood is low. And in clinical practice, you would codify that differently. You would categorize it differently for many reasons, one of which is you want to know what the problem is. What is the primary problem? So here, they actually clumped it all together in the data you saw. So they're looking at depression. They say, we don't really care where it's coming from. If it's depression, if it does what depression does, we'll go with it. And then as it lays out, there's other reasons as well. Okay, so kind of marching along, right? So we touched on this. So there's definitions, there's categories that you either belong to or not. What are those categories? So there's many, and we'll talk about, I would say, what are the 6 top ones. And this is the kind of thing you can just go, probably simplest place to look up something like this is the NIMH website. But there's a few other resources, and we can talk about those at the end if you want further information. So let's walk through this, because what this might help you see is when you talk about depression, you're not talking about the common concept, hopefully you've seen this, of somebody's mood being low, and that's it, done, end of story. It's a few more things that comes around for that. It's a syndrome, right? So it's a collection of symptoms that kind of hangs together for a period of time. So the minimum clinically is 2 weeks. So then as you parse this out and somebody walks in, and this is maybe a useful way to look at this. So you have somebody walks in, one of those people in that video, and says, oh, okay, there's this period, mood is low, and you see it. The mood is low in this person, right? Say it's false. Now you've got a question, right? So what is this thing in front of us? Is this major depression? Are we done? So you go down your list. You're like, okay, let's see what else is going on. Well, what else can it be? So there's persistent depressive disorder. So this is a little bit different than depression, major depressive disorder. Major depressive disorder, if you look at it and you're looking at force, it's sort of like this thud. If you were going to chart mood, it goes along and then it drops, stays dropped. And all those symptoms we were talking about stays dropped. And then it comes back up when the episode is done, and then you keep moving. And you could have another episode. Persistent depressive disorder is almost like if the baseline is like this, it dips a little at some point in the past. It could be a year, 2 years, 5 years, and then it just stays there. So baseline is here and you are here. And maybe major depressive episode is way down here. So you kind of maybe halfway there, right? Or maybe a quarter of the way. But you are not where your baseline used to be. You remember your baseline. And you're below the baseline, you just stay there. No episodes, no change. You're just there. And you can function, you don't have the whole collection of symptoms, but you got a few symptoms. And one of those has to do with this low mood. And it's not going away, whatever you do. So that's persistent depressive disorder. Then there's psychotic depression, which is a really severe form of depression. So psychotic depression would be somebody walks in with this low mood like we're talking about, and it looks like a depressive episode, right? So it just drops in terms of that episodic change in your trend line. As you have that drop in your trend line, the next thing that happens with psychotic depression, is you start to lose touch with reality. So this is a case where people may be thinking things, seeing things that do not square up with reality, right? They look at reality and they say things or do things that are completely unconnected and cannot be reconciled no matter how much explaining you do. And no matter how much explaining you try to do. So you could walk in there and have this conversation and it doesn't matter, right? Those lines are not intersecting. You guys are on two parallel tracks, right? Their reality is separate than yours. And it's insidious. So this is a particularly tough form of depression, not only to treat, but also to diagnose. And we can talk more about this later if you're interested. It's not super common, thankfully, but common enough. And like I said, it falls within a depressive episode. So you always have to look out for something like this. And these particular subtypes end really badly. So yet another reason to actually make sure you're not missing one of them. Postpartum depression, I'm sure you've heard of. Basically, this talks about depression that peaks after somebody gives birth, right? So you have a new mom, there's a child, this should be fun, right? You have this, of course, it's a lot of work. But that aside, for anybody who's had kids, a lot of work, but it's a point of joy, right? I mean, this is this moment you've been waiting for 9 months, and maybe more if you tried to have a kid for a while. And then the kid comes and my God, you're just not happy. You don't want to have anything to do with the kid. Everything about the kid is bad for you as a mom. And so it's kind of a double whammy because on the one hand, that's happening. On the other hand, the mom's often aware, right? So there's a pretty significant conflict because the mom knows that this is not okay. So it makes the person feel even worse. And there's other layers to that. There's some subtleties about how it presents separate from other depression. But again, this is a depressive episode that, if somebody walks in the door, as long as you can tell they've recently had a kid, then you can start getting on the right track. If you don't know that and they come, maybe a little further along, right? This is not day 2 after having birth. This could be day 30. Now, you kind of have to figure out, okay, where did this come from? What's the story? Because otherwise, a depressive episode is a depressive episode. Keep going. Seasonal affective disorder. So in this case, kind of a much more limited form of depression. And really, the seasonal affective is the key thing here. It basically means your mood changes with the seasons. And in some way, maybe that's intuitive. Oh, summer's here, great. But in this case, you're actually looking at loss of function, right? Somebody is not able to function because typically it's winter. Low light, obviously it's cold, sort of everything that goes with it. So interestingly, one of the treatments for it is based on light, right? In addition to maybe other things you might do. But again, when you walk in the door and, there's 12 months in the year, so somebody says, hey, my depression started month X, you got 1 in 12 shot. But you kind of have to dig a little, because maybe if the story is like seasonal affective, it's not one of these other things. It's pretty consistently something that shows up in the winter. So again, another variant of that same initial starting point where somebody walks in depressed. And then finally, bipolar depression is really, for all purposes in psychiatry, not depression, right? It's a different disorder completely. It's bipolar disorder. So, but the problem with this is that, again, like many of the others, when you walk in the door, you see someone and they're depressed, they have this depressive episode, that could be a bipolar depressive episode. There is nothing to say that it's not. So you got a problem, because now you got to look at the story around it and say, okay, well, what about, family history? That's one of the things you look at. What about other things that have happened that are very different than depression? And one of those would be, hey, your mood doesn't just go down, it actually goes up. And when it goes up, it just goes up all the way. So quote unquote manic episodes, right? Or hypomanic episodes, which are just sort of, you get the positivity that is completely out of whack. You literally wake up one day after having a depressive episode, no rhyme or reason, and that day is just great. Your mood is, you're on top of the world, life is good. It's not affecting you in a way that's creating major problems for your function, but it's really unusual. And it stays, right? It hangs around for a few days. It affects your sleep, it affects your impulsivity. You're more impulsive than usual. You might regret things that you do after the fact, because, hey, that's not like me. So, the reason the bipolar part matters is that it's impacting your decision making, your ability to think and implement things. But again, that's really a different disorder. But if you were to just walk in during a depressive episode and say, hey, this person has depression, yeah, sure enough, this person has a depressive episode. But it really turns out, both in terms of how the disorder plays out and also how you would treat this person, unless you did the right thing, the medication that you use could actually make the person worse. And again, these are some details we can go into later. I want to kind of stick to the phenomenology mostly. So this hopefully gives you a snapshot of the diagnostic challenge with some of the main types when you walk in the door. And you say, okay, I want something to help me figure out what a person has. Or more importantly, this person cannot get to me, because remember, we looked at that map. They don't have access. Or maybe they have access, but it's video and, not much more beyond that. Well, I want some more detail, right? Or maybe I don't have enough time with this person. I want technology to help me. So this is one of the challenges, right, on the diagnosis side. Okay. So we talked about those suicide graphs. We talked about the prevalence of this one problem, the impact of it. And then we talked about sort of types that might overlap in terms of what they look like, at least on a first glance. So why are those numbers so bad on the suicide front? So one hint about that has to do with treatment. If you look at these two snapshots, right, it's cross-section. So on the left is adults, on the right is adolescents. So below 18 on the right side and above 18 on the left side. They actually excluded kids, so it goes, I think, from like 11 to 17 or 10 to 17 on the right side. So what this is telling you is somebody walks in the door, there's a depressive episode, and you're asking the question, okay, what happened? What'd you do, right? Did you ignore it? Did you go somewhere? Did you get therapy, which is talk therapy, psychotherapy? Saw someone at all? And were you on medication? So as you can see, medication only is the smallest category of both. That's not necessarily a bad thing. For some people, maybe that's fine. They don't need a whole lot. Maybe it's a self-contained problem and it goes away. It's easy to treat. But most of the time, what you really want is a combination. You want the support from someone where there's an interpersonal interaction. So some form of talk therapy, and there's specific ones for depression, for instance. And you want medication on top if the situation demands it. So if you look at this, the thing that I want to highlight is the lightest one, right? So no treatment, 1/3, right, roughly, of 17 million folks, right, the adult side. On the adolescent side, which again here is 13% of that subgroup who are going through a depressive episode, it's 60%. So more than half of the folks who are dealing with this, right, where this is a real problem, right? This is not somebody's mood swing of the day. It's an actual problem that has an impact on your life, your function, your relationships, and puts you at risk for suicide, which we saw. 2/3 of those folks have zero treatment. So that's a problem, right? And here we're not talking about, hey, there's some rural fringe here where, you know, it's really hard to get to or something. That's 60%. So it's a big problem. So as we're kind of walking through and say, okay, where are the opportunities here? We talked a little bit about diagnosis. This is the other big one, right? So maybe it's because you're not getting diagnosed. Very possible, right? There's all kinds of data out there about how long somebody takes before they actually have their first episode of care, from the point they start having symptoms, and it's long. The statement from folks like NAMI, which is the mental illness advocacy group, national group, is years, right? So 5 to 10 years is a very common number they throw out. And that's, you know, really hard to reconcile. Imagine there was this debilitating problem you have. You know, you look at this pie chart. Obviously, they talk to someone because we figured out they're not getting treatment. So there's some point of access there, but no thanks, no treatment. 2/3, 1/3, and then the delay to treatment, right? So when you do get treatment, what this doesn't tell you is how soon was it, right? Was it that first episode? Was it within the first episode? Was it 5 years later when it got really, really bad? And, you know, you have to end up on the street or something, right? Or who knows what the trigger was that actually took you to treatment. So other layers are also important. And again, one of the things I'm getting at here, other than treatment being a problem, is that you need to get in early, right? So hopefully technology helps with that. Early identification, but also early intervention. Okay, so let's spend a little bit on anxiety. That was all about depression. So anxiety, again, maybe even more so than depression, is such a common word socially and can mean all kinds of things. And for most people, you know, it could be me being anxious because I can't play that video right at the beginning of this talk. Or it could be something completely different for the person involved. So one key way of differentiating is that it has something to do with job performance, schoolwork, work in general, relationships. So there's a sphere of life that is not working like it used to compared to when you have anxiety. And that difference is clear. And this doesn't go away, right? So going back to the point that needs to be treated. So just like depression, there are different kinds of things, anxiety that somebody walks in with could be. So a common one is what people call generalized anxiety disorder. And this is sort of the thing where somebody walks in the door, they're telling you, yes, I have this anxiety, and then, you know, usually it's my relative or someone that asked me to get in, maybe a spouse. And okay, this person's here, and okay, what's going on? And then you look at the picture, it turns out, yes, this person has anxiety from what they're telling you, and it's persistent, it's not just on and off. But the pattern is such that from every waking moment, they can't get rid of it, right? So open their eyes in the morning to the time they fall asleep, it's there. It's like a switch that cannot be turned off. Worry, worry, worry the entire time. And generalized anxiety refers to this aspect that the worry is about everything. There is nothing that is not part of the bucket. If it can be part of the bucket, it will be part of the bucket. So that's generalized anxiety. The switch does not turn off. And as you might expect, you know, if it's going from waking up to falling asleep, well, the falling asleep part is going to be a problem because you're not going to fall asleep. So very common reason for having sleep problems is anxiety being the cause of the sleep problem. And anxiety disorders in general are more common than depression. So you've seen the numbers for depression, anxiety is even higher, right, in terms of incidence and prevalence. So in terms of number of new cases per year, and people having them as a snapshot, say, over the course of the year, as in like how it accumulates. So that's one snippet, generalized anxiety. Panic disorder, this is, I think, closer to what people think of as panic, which is the so-called panic attack, right? So it's a very sudden change in state, and you see somebody in front of you, they're doing fine, and suddenly, rather than that person becoming obviously dysregulated, they actually become quieter, right? That's it's not easy to tell, but that's one way to tell that somebody has a panic attack. Everything just shuts down, right? So they if anything, they just kind of pull inward. But inside, if you were to ask them to describe what happened later, it would be as if the world just completely went off its rails. So panic disorder is basically having a panic attack with some other characteristics. And a panic attack is a sudden change in state, super high anxiety, on and off, happens maybe in the course of a few minutes to low tens of minutes. And then it's gone, right? Just as quickly as it came, it's gone. For some people, it's triggered. Typically, when you're talking about panic disorders, it's not clear what the trigger is. It's just out of the blue, as they say. And then there's a bunch of things that go around it, such as avoidance, etc. So it creates kind of a behavior pattern because the person's trying to deal with it in the way they can without treatment. Phobias are fears of things. You've heard, I think there was a movie about arachnophobia, so fear of spiders, and there's all kinds of other fears. So those are so-called specific phobias, like one type of thing that's bothering you, kind of the opposite in a way of generalized anxiety. And then social anxiety is social situations, right? So this is somebody where the problem of anxiety is so strong in social settings that they will go to amazing lengths to avoid these social settings. And that can become a very big problem, right? Because then you can't function in your day-to-day life. Say you're in school. School's a social setting, whether you like it or not. Yeah, you can sit in a corner, you can kind of avoid, you can kind of do your thing. But there's going to be a limit at which your normal function in school is going to be disrupted if social anxiety is a big problem for you, because you're going to avoid your way into trouble. And obviously, work can be that too, depending on what your work is. On the flip side, there may be some kinds of work where it's great. You don't have to talk to anyone, and you're good. But social anxiety is always on, which means it can be anywhere, right? So again, in the severe cases, marked difference. So now, using that same thinking we were doing with depression, walk in the door, somebody has anxiety, there are all these different paths, right? And purposely, I'm not covering everything. So there's a whole range of other things it could be. We talked about bipolar briefly. Bipolar is a high energy state for some people, right? When you're in the quote unquote manic or irritable state, it's high energy, as opposed to low energy depression. It can present with a lot of anxiety. So you walk in the door, you have somebody with anxiety, and now you're asking, okay, well, what does this person have? If you don't go further, yeah, sure. It could be somebody in the beginning of a manic episode, right? Where they're clearly not comfortable. Because mania doesn't always have to be pleasant. There's parts of mania, so-called irritable mania, where it's extremely unpleasant, right? They get set off. Or it can change a lot, right? Minute to minute. But underlying that, the thing that really bothers them is not all that other stuff. It's the anxiety. It's very high energy state that's uncomfortable. So this person walking the door, usually it's not a phobia, because phobias are often triggered, right? So it's like, hey, this is happening, and then this thing is triggering me to having this anxiety. So maybe that's a little simpler. Panic attacks, as we talked about. Panic attacks, so maybe in an idealized version, you could be totally fine in between panic episodes. But usually it's not the case. The baseline does go above normal. So if the normal's here, your anxiety level is above, right? And so you can kind of imagine, if this is a process where things are triggered, that higher anxiety baseline then makes it easier to trigger panic. So if somebody walks in with that higher anxiety baseline, you kind of don't know, hey, is this generalized anxiety? Is it a panic disorder? Is it something else? Is it somebody in the middle of a manic episode? And there's other things. There's, drugs. There's drugs that make you anxious. And so that's where you want to know, hey, is that something that this person came in on that you don't know? Or could it be a medical problem? There are medical problems that have very clear behavioral, you can call it side effects or part of their syndrome. Anything that affects the thyroid hormone can actually do that. Different ways, depending on the details, but that's one example. And there's other disorders. Some of them are infectious disorders that actually cause this. So again, just giving you, in medicine, this overall process called differential diagnosis. You've kind of seen it for depression and now for anxiety. You start off with something and you're kind of working through the tree, like where can it be? Like which decision should I take in terms of going left or right? So this gives you that window into starting off with something that looks like many other things. And then what do you need if you're going to use a technological solution to kind of navigate that? So just to kind of put this part together, starting with that initial quote about understanding the problem. So maybe we have some clarity, right? So there's a lack of access. There's problems with diagnosing people, right? If you're not coming in, of course, but also maybe you think you know what's going on with this person, but you don't have enough information or the right information. And you're not seeing it early enough. So what you're seeing is different than what this person actually has. And then untreated illness, right? So treatment is a problem, primarily because of access, but because of other things too. We didn't go into this a lot, but the disorder itself actually changes how you seek treatment. If you're somebody who worries a lot and you have this full-on anxiety disorder, you can imagine you're going to worry a lot about what that encounter with a psychiatrist or a therapist is going to be, and you're not going to show up. So missed appointments are going to be a big thing. Depression, kind of the other way, right? You don't have energy, you don't have motivation. So is it really reasonable to think that this person with all those issues is going to just come in full of enthusiasm and say, yay, I'm going to go see a therapist or psychiatrist? No, it's going to be much harder, but all the more reason, right? So, so again, three sort of basic aspects of the problem that need to be addressed. So what do we think, apps can do? So we talked about access. So apps can make it such that it doesn't matter where you are. It doesn't matter what time of day it is, because remember, it could be a panic attack, it could be something else, it could be one of those other problems like depression that's been kicking around. Well, if that middle of the night is when you want help and you're open to it, I sure hope somebody's making that connection, because that window might pass. It can be personalized, depending on what technology can bring to the table in terms of accessing and analyzing your information, so that you're able to learn, hey, this is what's specifically useful for me. And then engagement. We talked about how very often folks like this will not want to seek treatment, right? They may know they need it, but it's not a pleasant thing for them. It works against them because of the disorder. So your user experience maybe can be designed so that it makes it easier for this person to say, okay, I don't think it's that scary. I'm okay with starting to work on this app or work through this app, so that then maybe the next step is I'm going to go see someone, or I'm going to see someone through the app, even better. And I can do that quickly. Better diagnosis. So we talked about those vignettes where you're kind of navigating this path, and you want to know what it is you have in front of you, right? So one of the challenges is you need data, right? That's one of the biggest things that one has to do diagnostically. You need to collect data, you need to ask the right questions. You need to have time to do it, right? Sometimes that's the issue. So all of the above. And if technology can help the process of collecting data, that would be a huge, huge help, right? Because then you can start answering the questions that a lot of people will know to ask. But it makes it much harder when you have incomplete data and you have to ask those same right questions in order to get to the answer that'll say, okay, this is what I have in front of me. You can use other technological tools, right? Sensors, combining data of different sorts. And maybe this is one of the promises of current versions of AI, is that you have tons of data out there from people all over the world. And maybe that helps a system learn what to look for. So one individual, one patient, obviously experience, et cetera, is helping that person navigate this decision tree. But maybe one of the promises of technology is that AI can do a better job, right? And then give decision support. So as a clinician, you're kind of walking through your thing, it prompts you, right? So you're typing stuff up, or you're entering stuff, whatever it is, or maybe it's listening to you in an interview, and it says, wait, have you checked on this? Because maybe based on all these factors that have come so far, it's really, really likely that you need to ask about drugs. And I haven't heard you say anything about that. So that would be awesome, right? So from my perspective, those are the kinds of things that technology can really help with, because it can create a checklist that adapts to the situation. A sort of a checklist that's always there is partly what everyone's trained to do, right, as a clinician. But that can sometimes be impractical, right? And it can lead to problems, because you're not adapting to what the data is telling you. So maybe you need to spend more time on a certain subsection. So if the data and the analytics can kind of push you in that direction, ideally you do a better job, even in that first visit. And then treatment, right? We said treatment's a problem. So one of the ways that treatment's a problem, I don't want to talk about a lot of this here, but I'll throw this in this point, is one of the problems with lack of access obviously is no treatment. But then we talked about those other buckets in that chart, which were very small numbers, really low numbers for medication, and then maybe slightly higher numbers for therapy. The therapy you're getting is not the same no matter where you go. It matters where you go. So, and that's a problem, because you don't know that ahead of time. When you walk in the door, you don't know, hey, this tells me that this person's going to be doing the standard version, the evidence-based version that's succeeded in trials for the condition I want help with. So now that's a problem, right? Because maybe you're getting treatment, but your treatment is not what it should be. So it won't be effective. Same thing on the medication front, right? Is there kind of a somewhat algorithmic, evidence-based process, or is it sort of all over the place? So technology can help with that, right? Because again, it can help with decision support. If there's enough data, and again, in one of the challenges in psychiatry is that a lot of this is not like cut and dried. Obviously, that's why we're having this conversation. But hopefully, the idea of having lots of data and putting it together is that maybe it will start giving you some clues into, hey, this is the next thing to ask. And maybe with that next thing, now you can suggest, oh, out of X people treated with these cluster of symptoms and these other characteristics and demographics, 90% responded to medication X. Great. Okay. Well, that's better than anything we have, I'll tell you that. Now it's clinical experience, and mostly personal clinical experience with an overlay on your clinical training. And then this is, obviously speculative completely, but genomics and neuroscience are improving day by day. You've heard of all these genomic companies out there that are now able to genotype you on a consumer side and store this data and analyze it. Neuroscience, you've heard of brain imaging and how that's changing what we understand about the brain. So the hope is that those forms of data can start being integrated once you have a technological solution that's actually able to make sense of your clinical data, because it's kind of in the combination of the two that hopefully there's a high yield and at scale. Okay, so now let's look at what's actually happening. So this is one review, somewhat recent, where these guys looked at what they call ubiquitous technologies, things that can be all over the place, as they call anytime and everywhere, right? So this is our promise about location and time agnostic solutions. And in this case, I think they looked at what they called 46 technologies, so ways of delivering this sort of content to patients. And 13 of them were, so the bottom part of the pool here, were so-called non-clinical. and then the rest were clinical. So, and they used, this is not super important, but just so you know, they didn't like do a screen and say, I'm going to look for a search word, and that's how I'm going to look at what apps are out there, because there's thousands of apps out there. So what they did is they started with these things in bold as their anchors, and then they kind of worked off of those. So one thing referred to another, they kind of, filled their sort of pool. So top is clinical, bottom is not clinical. So what are they looking at? One of the things that jumps out at you, if you look at the disorders they're targeting, a lot of depression. So that's good, right? So if you want to know, hey, what's out there? What are people focusing on in these thousands of apps that are out there? Depression's common. Good. What is the form it's taking, right? So is it a wearable or mobile? I mean, very much driven by mobile, right? Your phone, most likely. And then the other thing, so, okay, so far so good, right? Easy to get to, it's your phone, everybody's got a phone. We're talking a lot about depression, okay, good. Maybe, we'll address that problem a little bit, anxiety. And then now the next part is you have to catch the problem, right? So the study part, N and T, so N is the number of people who are doing the study, right, in a given sample, showing you evidence that this app actually does something. And then T is the time, right, in days. So if you think of this, if a depressive episode, right, as we defined it, is 14 days, right, minimum, and there's no guarantee you can catch it right then. So when you look at these numbers here, they're not all big numbers, right? So there's a 14 here, there's a 1 here, 28, lots of 14s, and that's why you see the 14, right? Because the definition, right, of depression as DSM describes it is 14 days. So it's not a coincidence that these guys are hovering on the 14 here. And then the others, I guess, poorly defined or lower or inconsistent. So a lot of these are not really trials you want to be very happy about. So this brings up the second problem beyond sort of what's being done and how many apps there are out there is, are they doing the right thing? So are they having clinical trials where they're proving their technology? Are they looking long enough? Because if you don't look long enough, it's not clear that you're able to tell signal from noise. It's not clear that the signal you're picking up is real, and that the solutions then you can deliver are the right solutions. And then obviously the study size has to be big. And many of these are small studies, right? Two-digit studies, right? There's a few that are 3 digits, but really very few. And that's another problem, because anything you pick up in a sample of 10, 20, 50, can you really generalize that? Because look at the numbers out there, right? Millions, right? The people who are affected, geographically quite diverse. So how do you take this little snapshot and then say, yeah, I got this nice little result here. Okay, so am I going to feel comforted that that's going to apply to population of Bay Area, California, or California in general, or the West Coast, or maybe all of the US? Like, how do I deal with this? Because remember, one of our goals here is, at a very basic level, technology is going to be this gateway, right? Because access is a big problem. Well, then we want to know that this thing can speak to you. And so generalizability becomes important. And then on the lower end, this is a trend. I don't know if they look at some of the common ones. So some of the common ones you've seen, like Headspace, I don't see it on here. They start off, they're not clinical, right? So this is, we're talking about clinical here. So they'll end up in this lower bucket. So that's the other side, is that you may find these apps that are super popular, but they're like, no, we don't do clinical. So that raises another issue, which is, okay, now what do we do about that, right? Because it's not like just because it says we're not clinical, nobody's going to use it. In fact, maybe even the opposite, right? Because it's very appealing, well designed, and I have no problem with that. Go use stuff. But again, when I'm having that conversation, we can actually talk about it, because my patient's already seeing me, right? So in that context, you got a lot of room, right? You can discuss the app, you can kind of look at it together. But if our goal is, hey, the app's going to be this gateway, remember, the clinician's not part of the picture. So that raises the ante on what you expect out of an app. So something to think about. Now, different way to slice it, same guys. They looked at all these apps and said, what are they actually using, right? What function? So about a third, basically it's a user interface from my perspective. They're looking at how do I make it better for a person with depression, a person with anxiety, a person with something else to interact, right? Because that's important. If the way your cognition works, the way you're thinking, feeling is not, like everybody else, then your interface has to account for that. And that's one of the things I put in there, is that your user experience hopefully is a plus, and it makes you want to use the app and makes you want to do something about your disorder. So that's good, at least a third. A lot of them, and this is one of the big things that they found, which I think is true, at least in my experience as well, is that sensors are part of everything, right? So, and it doesn't have to be a separate sensor, right? Because as we saw on that list, it's all mobile. So it's sensors within your phone, right? And a lot of the apps are based around what are those sensors picking up. And these are, passive versus active sensing, which is another topic, which we can go to a little later. Something to think about. One of the things I'll tell you just from personal experience is whenever I have somebody do something that's active sensing, hey, write down this, write down that, honestly, yes, maybe it creates a better format for you to put something down, and maybe it's mobile, you can carry it with you, it's convenient, but it's work. It's extra work you're making this person do. And the more you want this person to do who's already not doing well, it's very unlikely that will continue unless there's a lot of pressure. There's some kind of pull to make that happen. So active strategies are a real problem, and that bears out in the data. So some of the surveys out there will say people use these apps, they download a bunch of them, use them for no more than 5 days, and then that's it, forget it. Other ones will look at it and say they use it for a few days, come back, and then, a large percent of the apps don't get any use after maybe the first week or two. That's it, it's over. They'll come back maybe once. So we got a problem, because we're talking about, in this case, depression, anxiety, right? Minimum episode length is, a couple of weeks. But we're not just talking about that. We're talking about making sure they're okay beyond that, right? Because it's not like depression ends on day 14. It can last for years, especially if you have persistent form of it. So how do you make these apps useful? So that's another technological challenge, is that it has to have the ability to grab the person in a useful way for a long length of time. And consistency is important. So passive might come into play, because then they don't have to do anything. It just has to be, they have to not deactivate it, and they have to not get rid of their phone, or hopefully if there is something that happens with their phone, they put it back on the new phone, etc. So something to think about, active versus passive. I would say on balance, the amount of friction as well as the sort of characteristics of use look a little better with passive sensing apps versus active. And then there are a few other categories. I mean, interventions is obviously an important one, right? So we talked about therapy and how apps can maybe standardize the approaches to therapy or algorithms. And so a quarter of them did that. That's good, right? Because then maybe, okay, now we're getting somewhere. Maybe the app tells you, if you have X, come to me and I will set you on this plan. Okay, good. Predictive modeling, a third. So one of the things about predictive modeling is somebody with depression, they're kind of marching along, and maybe it's them, maybe it's their family, want to know, hey, how am I doing? Like, where's this going? So ideally, technology can actually be able to look at tons of data and say, out of all this cloud of data, this is you, and our best guess is you're doing well. This is going to continue. Or our best guess is this is a problem, something's going to happen. So high alert, do the kind of psychosocial things that'll prevent you from getting into the next problem. So that would be immensely useful. It's not something we can do. The data now shows that obviously it's clinically driven now, right? It's your individual providers who are making these guesses. And typical appointments can be very far apart, even in people who are sick. So for a variety of reasons. And that's a problem, because your data is very sparse as a clinician. And it leads to all these problems we talked about in terms of access. So even if you knew something, by the time you get to that, things have already evolved. So predictive modeling can get around that, right? Because you can stratify, right? If you have 100 patients, how do you kind of work that through in a clinic? Clinical assessment, this is standard clinical tools. A lot of them are question-based, right? And maybe this provides a better way. But generally speaking, it basically puts those questions in electronic form. Ideally, what you want is some kind of an interactive way that, I don't know, maybe you could be playing a video game, and then by basing it on your interaction with that video game, it's actually extracting the features that you really want in your clinical assessment. So from my perspective, that's what I would want it to do, right? Because that has a huge sell in terms of the person wanting to do it. And in a way, it's smarter, right? Because the person is not aware of what you're checking, so they're less likely to influence it, good or bad. So few things to think about. So different study. These guys, what they did, again, somewhat recent, they said, okay, we're going to look at Android and iOS here, phone type, and we're going to pick 6 categories, and you'll see it a couple of slides down, which are basically diagnoses, right? Depression, anxiety, etc. We're going to pick 6 categories, keyword-based search, and we're going to pick the top 10 items, right? So they ended up with 120, so 10 Android and 10 Apple for each of the categories. And then we're going to use this sort of format. Does it meet the WHO criteria? What kind of a rating? Has it been, reviewed popularly? And does it make any claims? Hey, as opposed to, wellness, feel good, or this is to treat depression. And does it deliver on that claim? Because that's important, right? Because now you're starting to get in this territory where you're saying, okay, this is actually a thing I would prescribe to you. Or maybe the person, consumer, just picks it up, right? It's better than doing nothing is the idea. Well, is it? We don't know, right? Is it better than doing nothing? Because again, remember, these apps, nobody had to approve anything for them to be on the market, at least, as of these reviews. So does it have a social component? Does it give you gamification so that, makes you want to do it? Does it help you chart things? Does it use other wearables, other devices that then brings in data, GPS, right? We talked about how one of the promises of using technology, especially AI with lots of data, is that you can combine data from all these different sources, which is really very different than what we do in clinical practice and what we can do in clinical practice. So that would be a big plus if we're able to use that data and derive some meaningful insights. Okay, so this is how they did. And then one punchline for this particular study is that literally the only correlation they could find is that the popularity in terms of, hey, this is 3-star app or whatever, 3 out of 3 stars, was related to how recently it was updated. So the longer time to update, the fewer stars. That's the main finding, right? Out of all the digging that they did. And, probably expected a little more out of it, but that's what they got. Then they went back. So the first one was survey in 2018. They went back in 2019. I just got it from one of the authors, John Turris, who's on the East Coast. This one, again, very similar, right? The format looks a little different, but it's all the same stuff. There's features, there's interventions, there's all these claims, and then the same rating stuff. And maybe they added some more text reviews as all the metrics they're using. Same format, 120 apps, 20 for each category, Android and Apple. Okay, so what? So one of the questions they asked is, okay, well, we had those results to begin with. Did things change? Because now there's tens of thousands of these things. So maybe things are better. So their outlook is maybe even less positive than my punchline there. They basically say nothing's changed. It's bad. And to give you kind of a snapshot, let's look at this, right? So medical claims, so 15% for anxiety. We'll look at this column. Anxiety is the category. So apps for anxiety, 15% made medical claims, right? So most of them don't even bother, right? Clinical, don't use us. Depression, 45%, okay, coin flip. So that went up, right? So year by year, 2018 to 2019, almost doubled. Here, it quadrupled. So that's great, right? A lot more people making claims. However, look at the percentages here. If you were to go back to these apps in each of the years and say, okay, well, these are the numbers of people that made these claims, well, how many of them delivered? only 5% delivered. So a third of the people that made the claims delivered on those, on any evidence. We're not even talking about the quality of evidence here. We're just talking about any evidence. And the same thing here, about half. And then here, it's a little worse. So with depression, 0% had any evidence to suspect. And then 10%. So that's a big change, right? 0 to 10, right? Went from nothing to something. But again, really low. So 1 out of 10 apps have any evidence at all to support that their app does what they claim it does for a medical condition. So this is a problem. Like if you were to talk about treatment and say medication, right? FDA approved medications on the market, it's kind of like saying, well, there's this medication. So first of all, it got on the market, nobody really had to do anything. And then second, I'm going to say some portion of these meds, you know, in this case, 45%, yeah, they're for depression. And then 0 of them have any evidence to tell you that it's actually for depression, it's going to do anything. So this is a problem, right? Because if your standard you're walking in is, hey, we got psychotherapy, we got meds, we got, you know, other interventions we haven't talked about, there's brain stimulation, etc. So that's kind of our backdrop. And now we're saying, okay, now let's start using technology and see where we are. We're running into this problem where the idea of the technology being serious about making a medical claim appears, you know, sort of either not super great or maybe a little better, depending on the diagnosis. And then 2, on following through is really bad, right? So you make the claim and then you don't really bother doing much about it. You might see stuff in ads, but if you go look for a study, it's not there. And certainly a study that supports your claim, it's not there. So this creates a problem because now everybody has access to the stuff, right? Nobody's out there saying, hey, don't use that app for depression because there's 0 data to support it. Or there's maybe even something wrong. And this is one of the things that, you know, one of the recent papers goes into is, well, what are some instances? Because when they did some of these reviews, one of the things they found is this one person, I think, who had bipolar and had these symptoms related to bipolar. The recommendation was go drink alcohol to chill yourself out. And that is not a good way to go, right? So that's one of those examples where you look at, okay, we got whatever we have going on, and then we have these apps. Is it better to do nothing, or is it better to go try your luck with that? In that instance, it would be better to do nothing, right? Keep doing whatever you're doing, because you go follow that advice, it's going to be a problem. So as we're talking about promises and kind of great things that can be delivered, the flip side of this is, you know, there's some problems as it stands now. So we're getting close to the end here. So I thought one thing that might be useful is to look at, so we have these ideas about what we want to do. And we saw what apps are doing today. What is a way you can envision this, right? How, if we were going to just start from scratch and say, okay, I'm going to design this thing and I want it to help anxiety and depression. How do I want to look at this? So one way to look at it is to look at it from the life cycle of the problem. Prevention is the best, right? If you can do that. And maybe technology can help with that, right? Because we haven't really made a dent in that at all clinically. So what would that mean? That would mean analyzing family history, right? Very doable. The data is there, right? Somebody has to get it. Temperament, again, the data is very collectible. There's all these tools, and probably technology could do an even better job, right? And there's these predictions that, you know, you can actually use temperament that was gained in the first year of life, and it holds true decades later. Genomics, again, the technology is there. The science may not be there, right, for things like genomics and other brain imaging, et cetera. So that remains to be seen. And then there's all these personalized wellness tools. So maybe you can have healthy habits. It's like, hey, physical fitness, right? So we know if you do X, then that prevents Y. And maybe doing those studies to actually show that. Early detection. So here, basically, maybe if you have people, because now, you know, you've seen Apple doing some health stuff with heart rhythms, et cetera. So once you start having signatures that you can detect that correspond to some of these diagnoses, or maybe subsets of symptoms even, then your sensor should be able to pick that up and alert, right? Based on hopefully the tons of data that you're getting from all these millions of people with these devices. And then maybe you can have a little stress test to say, okay, is this real, right? So that would be one way. You actually test this person in whatever small way to sort of say, okay, is this false positive? And then you can start delivering some personalized options, right? Because hopefully, because that person is using their wearable, their device, maybe there's some data there that makes it unique to them. Access can be timely, right? So you literally pick up the phone, and through that, there's a video interaction or whatever it is you want. You can do decision support like we talked about. You can now diagnose and track the treatment, right? Because being lost to follow-up can be an issue, as well as outcomes are a problem, like we talked about, when the information being provided is not good. So this is a way to kind of track all that, which is an advantage of technology, right? It's always there. Like you're not going to lose your piece of paper or notebook. And then finally, adverse events happen, right? As you're learning to work on these conditions and more, you want some way to pull the 911 button, right? To say, oh, something bad's going on. And ideally, earlier, better than after the fact. Kind of like what we do in cars, right? With all the fancy tech. So this is just something that I thought might be good to kind of put it together. So as we're thinking about the technology side, how do you make it so that people want to use the app? Because we know that currently that's a problem. And how do you make it stick? So one of the things that's come up as a recent sort of understanding of the dynamic in how people use apps is there's a problem with transparency and trust, right? And I'll give you a little vignette. Edward, how am I doing on time? You have a few minutes?
I think, yeah, you can actually 5 more minutes.
Okay, that's perfect. This is my last, I think this is my last slide.
Yes, okay.
So, so I'll give you a little vignette on the transparency and trust. So my older one, who's 15, she was looking at me making these slides. I was like, hey, what are you doing? Because I'm not, these days I'm doing other things, not making slides. So then she says, looks at the thing, it's like, oh, AI and psychiatry. I said, yeah, isn't that cool? Like, wouldn't you want to have an app where you can go do this thing and it'll work with you? And she's like, oh, that's creepy. I'm like, wait, what do you mean? Like, it'll be smart, right? This thing will be smart. She's like, oh, that's even worse. So I said, wait, what do you mean? Like, you should be excited about this. She says, no, if it's smart and it knows all the stuff about me, it can really do a lot of damage. How do I know it's going to do the right thing for me? Okay, that's a fair point. So it turns out that's not just her. If you look at sort of some of the recent papers coming out and conversations about this, that is one of the big issues. How do you build transparency and trust? And I'm sure on the tech side, you guys are completely used to this. But this is new in our part of the world because a lot of the stuff we do is very much based on interpersonal interactions and building this. So whatever you do with AI has to have that as a very central thing, because otherwise people are not going to engage, or they're going to give data that's useless. And once you have that, I mean, it's like you've done nothing, right? Because if that engagement and that data flow isn't there, you haven't moved the dial. There's no chance in moving the dial. Consenting matters. So often with mental health, there's this issue that the person could have limited ability to read these very complicated legalese things. So it needs to be simple, right? Because there's problems with equity, access, fairness, etc. And unless you make the consenting process simple, it kind of goes along hand in hand with trust, and it can create some problems. And people, again, the result will be the same. They won't engage. They'll be like, oh, this stuff looks like I'm going to be in this trap somehow, and my data is going to be sold, or it's not going to be private, or whatever. So I'm not going to bother. Interventions need to be proven. So, we looked at the data. That's one of the big problems with the data right now about the apps that are out there, is that the apps are coming before the interventions that work, right? So there are things out there, right? To one of the comments that came up about Insel, So, and if you've heard him talk, one of the things he'll talk about is for many things, we actually know what to do. It's to make sure that's done reliably wherever a given person goes. So ideally, that's an app, right? Easy to get around. But what is a way so that there's kind of a central collection of verified, proven things that can be pulled from, rather than I'll just kind of do whatever seems cool at the moment, which seems to be what's going on. Maybe that's too flippant, but that's what the data seems to indicate. Friction needs to be low. So one of the big pluses for apps, like, hopefully I've tried to show during the clinical workflow, is I can make that job so much better and so much easier, so much more efficient. But it's not going to do that if it doesn't fit into the workflow. So as you're designing an app, as you're designing one of these technological tools, it's really important to understand, what does the clinician do at baseline? And where can we fit in so that it makes that process move faster and easier and doesn't disrupt it? And I think a lot of things that go wrong in that sector with health tech, from my perspective. Passive monitoring, we talked about active versus passive. The less you have the person do, the more you're likely to succeed in consistently getting data and in consistently getting engagement, especially with mental health. And then, the other thing we haven't talked about that much, but one of the data points of that initial review was that lots of mobile devices are being used in these apps. That's great. But one of the problems is you're using what's there. So something to think about is there a way to either modify the device or somehow alter the sensor characteristics, maybe using software, I don't know, so that it's actually better tuned for the task at hand. And we didn't go into a lot of this, and we can talk about it briefly if we need to. But what are those modalities that matter more to mental health? Taking pictures is probably not the biggest thing, right? And the camera is getting better and better on these phones. But what about the other stuff, such as voice and sub-fractionating components of voice and movement, and making sense of lack of movement versus movement and where they are in their normal routine, etc. And then finally, this is definitely last but not least. So one of the big things in treatment for mental health is how you involve social support and family. Because the person's obviously struggling with something, they're not going to be the solution to everything, right? Because that's by definition. There's a problem they're dealing with. It affects how they think, work, function. And so the more support you have around them, everybody knows they do better. There's plenty of data to support that. So the more an app can do to make that more fluid and flush it out more, the better it'll succeed, because you're actually solving one of the social problems, right? I'm sure you've heard about loneliness, epidemic, etc. So if an app can help put together what in real life is really useful and have an intelligent approach to it, right? It shouldn't just be a simple transaction of like, oh, click this, and then somebody has joined that network, and then, okay, it's done. Well, it's not that simple. Maybe there's a lot of conflict within the family. Maybe that's the focus. So, but there's no reason technology cannot help with that, or at least to facilitate that process, set up the groundwork. So I say last but not least, because that's a huge, huge part of making sure people stay safe and they stick with treatments. There's multiple eyes and ears on them, so to speak, right? You almost want to build this empowerment in an individual who's suffering from stuff, so that they feel comfortable to say, hey, I want my parents, my relatives, my best friend, whoever, my partner, to be this person who has a outside view of what I'm going through, so that they can give me objective information. And that can be a really powerful thing, because that's a human brain that you then add on to the app. So I'll end with that, and if you have any questions. So thanks again for this opportunity. You guys have been very quiet. Hopefully this has been at least a little bit interesting.
Yeah, thank you so much, Dr. Duvvuri. So I think it's kind of nature, these online courses, interaction is much less. Maybe I didn't do a great job to encourage questions. Definitely very, very edifying. I learned a lot from the lecture. I didn't really understand there are so many different subtypes of depression and the anxiety disorder. And I learned a lot of apps trying to track motions So let's say if I wake up pretty often in the nighttime and to get into social media or checking my email, and that probably displays the truth. I don't sleep pretty well, or my motion jitters all the time, shaking my legs or something like that. Maybe anxiety is kind of higher. So prevention, yes, I do believe there are many things we can do, but treatment will be challenging. Yes.
Yeah, and motion, that's an interesting thing. Obviously, really easy thing to collect data on. One of the challenges, I think, is that, how do you approach the motion problem? Do you approach it individually, where you're really looking at the individual's baseline, and then all the motion signal to noise is based on that person's baseline? So far from the data I've seen from tech companies, that seems to be a more promising way. It's still super noisy. Or do you aggregate and try to learn from that? And so maybe there needs to be some analytics there to sort of say, how do you retain the value of individual data streams, and then somehow then normalize it so that then you can aggregate it across a big population, and you still have whatever is valuable out of that individual string of data. Because at baseline, there's a lot of variability in a lot of people's behavior.
Yes.
And that creates a problem to pick up what you're talking about. Whereas with a human, there's a meaning to the motion. So it's not just motion. Oh, they did this in the context of this. So I'm going to parse that differently than if they had the same amount of motion in a different context. But again, I'm sure you tech guys will have lots of fun with this stuff.
So thanks again. And because of time limitations, we will end today here. But I think if you have any questions or any subjects you like Dr. Duvvuri to cover even in depth, and we may have a chance to invite Dr. Duvvuri to come back in a few weeks. And so thanks again, Dr. Duvvuri. Outstanding talk, and see you next time.
Yeah, thank you. Glad to be able to share. Bye.
Bye-bye.
Thank you.
Thank you.